So HAE, it's first of all no disclosure because I'm going to talk about a lot of medication. I have no disclosure. These my objectives. I'm going to give a quick overview about the hereditary angioedema, the pathophysiology a little bit, touch base on this, and then I'm going to talk about the key component, key pathogenic component pathways of hereditary angioedema, and then the advancement in the treatment. For who never know or doesn't know what's hereditary angioedema, it's basically an angioedema that it does not affect the superficial of skin. It's deep down in submucosal tissue or mucosal tissue, and it's rarely causing any itching. It has no cellular infiltrates. It's mainly fluids, and usually it's autosomal dominance. And it's even if you have one single gene that you may develop angioedema or hereditary angioedema, and it's usually lasts between 2 days to 3 days. So we used to know that hereditary angioedema it's 3 types, but now they moved the paradigm to say it either hereditary angioedema with dysfunctional or abnormal C1 esterase inhibitor, or which encompasses the first well-known 2 hereditary angioedema, which is the type 1 and type 2. Type 1 is related to antigenic deficiency, and type 2 it's basically related to the protease inhibitor functional issues. But the newer one that recently developed was the first one presented in France, in the family in France. It was related to factor 12, the hangman factor 12, and that encompasses only 1/3 of these hereditary angioedema with normal C1 esterase inhibitor. However, the 2/3 till now, we don't have any genetic background for those. So C1 esterase inhibitor, it's basically can be in anything, can be involved in many things. There's 3 main components that has role in C1 esterase has role in them. The first one, and which is the biggest one that I'm going to talk about it today, is the contact pathway. It has some role in a complement pathway and the fibrinolysis pathway. All of this, when the C1 esterase is intact, it keeps the homeostasis in the intravascular volume. So the contact system. We have something we call micromolecule. That macromolecule in ex vivo, it's a negative charge. But in vivo, usually they couldn't localize what exactly the in vivo molecule that caused all of this. But they have hypotheses. It could be heparin, or it could be other molecule. So the factor 12, it's attached to that molecule, and it's constantly breaking down to active form of factor 12. And that's what happened. When it's overactivated, they produce more and more of factor 12. When you have too much factor 12, the prekallikrein get activated and produce the kallikrein. Then kallikrein, it has a back positive feedback that keep more and more of the factor 12, activated factor 12, basically synthesis. And the other things that kallikrein does, it basically goes to high molecular weight kininogen that basically when they attach together become a complex, and that complex basically produce the bradykinin, which is the one cause all the problem in hereditary angioedema. So we have the end product is bradykinin. So where is the C1 esterase basically work? Basically works in all these steps. So basically it stops the conversion of the autoactivation of the factor 12, and also it prevents the prekallikrein conversion to kallikrein. Also the negative feedback, also the molecule, the complex to be developed. So the end product, it's basically preventing bradykinin to be produced. Having said this, not only hereditary angioedema can cause angioedema. We have the two that we talked about here, the with a normal and one with a deficiency. But also we have, and all we know that ACE inhibitor can also cause angioedema. But if you take a look, all of them is related to the bradykinin. Here in the first top, it's basically because of increased production. But with the ACE-induced angioedema, it's basically because of prolonging the bradykinin, because ACE basically cleave the bradykinin. So to diagnose this, basically, we have to have a very good history. And the most important thing in the history, it's a family history, because it's a hereditary disease. The clinical feature, as you saw that couple pictures, is basically have angioedema that mainly involve face, limbs, and GI, intestine. And the one we are always afraid is asphyxiation, which is a laryngeal edema. And then we have to have a very good laboratory diagnosis. Basically, we have to check the C1 esterase level, antigenic level, and the function of the C1 esterase inhibitor, and then the C4 and C1q to just to differentiate between acquired form as well. So, what's the goal of the treatment? Basically, the goal of treatment is to prevent death, and most of the time, those people die because of asphyxiation, which is basically closing of the larynx. And the other thing is basically to reduce the frequency and the severity of attacks. And we basically can approach this by targeting two things. Either an acute event, we try to abrupt that event, or by preventing this to happen from the first place. So for acute event, we basically trying to stop the process of kallikrein kininogen system and eventually the release of bradykinin. And this can be done by multiple medication. I'm gonna just briefly mention those. And also by blocking the effect of bradykinin itself. And the key of these treatment, acute treatment, is to have it as soon as possible. The soonest is the better. And by prevention, we basically have two ways of preventing attacks, especially people who is well known that they have hereditary angioedema. Short prophylaxis, which is basically happens before any procedural, especially dental. And the long term, and this can be done by androgen antagonist or the C1 esterase replacement therapy. And the second one is basically the long term therapy prophylaxis. And again, it has been, can be done by the androgen antagonist as well. For many years there have been those being used, but unfortunately it comes with its side effects because we're talking about metabolic medication, so it has a lot of side effects. And the antifibrinolytic, even though we don't know how they work, they have hypothesis this plasmin can activate also the factor 12, but again, it's not as effective as the androgenic antagonist. So the treatment strategy, that's what the key or the meat. We either replace the C1 esterase inhibitor, and there's two forms that how we can replace them. It's basically plasma-derived or purified C1 esterase or recombinant C1 esterase inhibitor. And the other one is basically by inhibiting the activation of the contact system, or the one I showed it to you before. And there is many targets in those in that pathway. And the last thing is basically by blocking the receptor that the bradykinin work at or on. So this is the diagram that I just showed you in a minute. So basically by supplementing C1 esterase, we block many steps. So it has the major effect on most of component of this pathway. Now, the trials I'm gonna go over. The one is highlighted in red. It's the most recent one. It's actually I could say the last 2 years of hereditary angioedema patient is the golden 2 years. Probably there is 5 to 6 publication was done in the last 2 years on good medications, really good medication. So Burnett, which is basically the IV form of purified plasma-driven C1 esterase inhibitor. There is first two trials was done in 2010, and it was IMPACT 1 and IMPACT 2. But the recent one, the most recent one, is basically the prevention, and it was phase 2, and it's called Combat. These are the doses they used. So basically, this is the acute event one. You can see the difference here. You can see the difference here within 48 minutes, only 48 minutes, 50% of patients who had acute event, basically they start to have complete resolution of their symptoms. And there is two different doses. Basically, the higher dose, it has the higher effect. And this was shown also in Impact 2, where it's basically for the last 24 months, people who had on-demand use of this treatment, they have lower timing of resolution of their symptoms. The subcutaneous one, which is the one was published in 2017, that was more frequent doses, even though it says prophylaxis, but the patient has to take it 3 to 4 times, every 3 to 4 days. So they have to take it twice a week. So even though with that, those patients basically they have almost 40% of those patients, especially the higher dose, they have no recurrence for their symptoms while they were in treatment. And this was taken only for 14 weeks. And even though if they had the recurrence of their symptoms, it was less severe and less shorter of duration compared to placebo here. Now, so this study actually, it was only 14 days, but now there's an extension of this study. They're shooting for 52 weeks. So we'll see what's going to come with that study. The second one is called Sunrise. It's again the same thing. It's a plasma-driven C1 esterase inhibitor. The two studies was done. It's changed 2 and it's changed 3. One it was for acute and the other one was for prophylaxis. This is old medication, has been studied very well, and actually this is the only medication accepted from those formulas, accepted or FDA approved for prophylaxis. The dose, it's easy to calculate. Here, if you can see, was actually the one before. It was based on the weight, but here it's fixed dose. It's 1,000 international unit for acute, and you can give it afterward if the patient's symptoms didn't resolve within 60 minutes. And the same thing with the prophylaxis, 1,000 international unit every 3 or 4 days. So again, the results, it's the same. People responded very well to the treatment within almost 2 hours. And when they really did dig details of this, those people, they've been on placebo the first time. The same patient, after they took the same C1 esterase inhibitor, basically the normalized attack rate went down. And this is the diary of the patients. Basically, you can see this patient, for example, it had multiple attacks, but when they went on the C1 esterase inhibitor, basically it's normalized. Now, they decided we have to go and do the prophylaxis, but this is with a longer duration. This was just released on the clinicaltrial.gov, but there is no publication yet. Basically, it showed that even with this treatment as a subcutaneous. By the way, those two things, even though it says prophylaxis, it was intravenous. So this is what they did. They did a subcutaneous one now. And basically, it showed the same result as well. It decreased the recurrence of the symptoms or occurrence of the symptoms by almost 2-fold. The second one, it's Ruconest. Ruconest is basically similar, but it's recombinant. So it's not purified from human plasma. It's basically a rabbit. They get it from the rabbit, and basically it does the same job. But here you have to be sure that those patients, they don't have IgE to the rabbit. So this is one of the criteria as well. Those patients, I'm going to talk exactly about the newer study, which is basically the phase 2, and it was subcutaneous as well. Oh, sorry, this was IV. Again, it showed both people who received the treatment, they had quick reduction and start of resolution of their symptoms. When they did the intention to treat analysis or per protocol analysis, they showed that both of the treatment, they showed a good effect. However, with the twice weekly, they showed better of response to the treatment. Now, we move to the next one, which is basically the receptor antagonist. We have only one now approved or being studied called icatibant. There is 3 trials, all trials. It was published in New England Journal of Medicine, Phase 1, Phase 2, Phase 3. All of them, they use the same dose. The only difference between Phase 1 and 2, it was basically what's a placebo. One was a placebo, and the second one was tranexamic acid. With this, they showed after 4 hours, basically there is a 67% start of resolution of their symptoms compared to placebo. But however, with the tranexamic acid, it showed up to 80% resolution of their symptoms, or start resolution of their symptoms compared to 31 on people with tranexamic acid. For a complete relief of their symptoms, basically only took 8.5 hours compared to 18.4 hours in people with a placebo. And here, with the other study, the Phase 2, it took only 10 hours compared to 51 hours in the people with tranexamic acid. This is Phase 3. It showed again and again that only can take up to 2 hours at the median compared to almost 20 hours in the people with a placebo. The second one, eclanetide, which is a Kalbitor. Basically, there's 2 studies was done. It was edema 3 and edema 4. Both of them were double-blinded placebo trials. They used subcutaneous treatment, and basically, again and again, it showed there is a big effect after they blocking the kallikrein, and there is after 4 hours, there is a higher reduction or a quick resolution of their symptoms. When they compare the sustained improvement, it's up to 30% compared to placebo, and significant improvement, it was up to 20%. This was the major. This is among all of those, this is the major. It's This was the major. Lanadelumab, basically it's a monoclonal antibodies that targeted again kallikrein. But the beauty about this medication, it's basically, even though it's a Phase 1b trial, but the beauty about this medication, it's once every 2 weeks. So instead of giving all these medication twice a week, either subcutaneously or IV, this one you have to give only 1 injection every 2 weeks. So it has, has longer duration, and you don't have to give it too frequently. They did range doses trial, and they found all the doses, it has the same half-life. However, when they compare the placebo with the 2 higher dose, the 300 and 400 milligrams, they found, this is the cleavage of high molecular weight kininogen. They found that that medication stopped the conversion of high molecular weight kininogen to bradykinin at the level almost close to the control level. So it was high suppression of the conversion of high molecular weight kininogen. And the attacks almost become 0 in the people with the 300 and 400. The next medication, again, I keep saying this is going to be a breakthrough, this is going to be a breakthrough. This one, again, is going to be a breakthrough as well. This is a Phase 2 trial. The beauty about this medication, we've been saying that all these medications subcutaneously, IV, but this medication is an oral medication. They take it daily. Just imagine that you don't have to take an injection, just take an oral medication, and you stop all your angioedema. They did arrange those as well, and they found that with the 125 milligrams, there is a good effect and prevention of attacks, up to 73% prevention of an attack. And the quality of life improved significantly in the same dose as well, at 125 milligrams.
2 minutes.
Okay,
2 minutes.
almost done. Avrostat, again, it was a blocker for the prekallikrein. Even though it showed some promising results on the phase 2 trial, but unfortunately at phase 3 trial, it didn't work. So probably they're going to repeat it again to show there is maybe faulty in their study design. The last two things I'm going to talk about are still in the pipeline. They start targeting the factor 12 now, and also they start targeting the prekallikrein at a different site compared to avrostat. So what about the pregnancy, lactation, and childhood? Till now, the FDA only approved for the purified plasma-driven C1 esterase. However, if you have access to those medication, you might use the other ones. The only one approved so far for the pediatrics, it's a purified driven C1 esterase inhibitor, and eclinitide only for 12 and above. But in Europe, they can go lower than this, even 2 years. Icatibant, it can be given at less than 2 years old, only in Europe. But in US, it's more than 18 years old. So, the last two slides, the future directions. So basically, we have, even though I've shown you multiple good results and good medications. However, we don't have access to those medications. The only one I could have known of, it's icatibant that we have. We don't have much of access to the other medication. So we have to broaden this access to those medication. I know one case is getting intubation every time gets to the hospital. He has so many trachs. We have to get this medication. We have families that already know that they have this condition. Lucky of them, if they go to a good hospital, they have access to those medication, and all of them, it's non-Saudi FDA approved, so we have to get this Saudi approved, and then we can have it for our patients. The key of this, it's early diagnosis. If you get it early diagnosis, probably you're gonna save patients from laparoscopic surgery or laparotomy. You save them from intubation, from trach, from many things. And we have to develop more other treatment like that one I showed to you, which is oral. And basically gene therapy, they just started in animal models now, but I think we have to move with this, especially we have single genetic defect. So in summary, the early molecular and functional diagnosis is the key for the management. Early patients should have an acute care plan, and they have their medication on demand because they have to give it, as we said, the earlier is the best of the treatment. And C1 esterase inhibitor, eclinitide, and icatibant are the effective treatment for acute treatment. The higher dose of C1 esterase inhibitor associated with more rapid response and higher response rate. However, this is only an observation. There is no guidelines about this. And the earlier treatment is associated with reduction in duration of swelling, pain, and disability. And the last thing, prevention of acute attacks or reduce the duration should be the ultimate goal for this treatment. Thank you.